I know you are putting up a lovely thing called Medicine by Design. Can you maybe educate our youngsters? Is that working? Is the mic working? Okay, great.
Yes, it's fine. Well, good morning, everybody. I'm Armand Keating, and I'm delighted to be here. I wasn't expecting to talk about medicine by design, and this is not my program, but this was a federal Government of Canada initiative, which was a competition, and the University of Toronto was successful in obtaining a very large award, and the proposal was to provide several pillars to develop regenerative medicine. One of those was cells by design, the other was tissues by design, and the third pillar was organs by design. I can't tell you about the results of that, but what I can say is that it's been very, very helpful to the University of Toronto to have this independent form of funding. I guess we're, for those who have just come in, I guess we're waiting for the slides to come up so that I can give my presentation.
Yes, sir. Is there any question that you have on medicines by design? I would also like to state over here that it has been the University of Toronto which brought out for us insulin. Everybody knows insulin. Am I right? Am I right?
You're absolutely right.
And from a little garage or something like that, which Dr. Banting was given to do his research on. Can you give us some insights? Because I can see there are a lot of students out here.
I'm not sure that I can provide very many insights, but Banting and Best were the investigators who were able to isolate insulin, and that was really the beginning of the development of insulin. And I think, if I'm not mistaken, the development of the Connaught Research Laboratories, which provided insulin, and I think gave the first treatment of insulin to diabetics. And the research is currently proceeding quite actively. Perhaps I can...
Now we have it going.
Thank you.
Thank you very much. So we have Dr. Armand Keating giving you the presentation on cell therapy with permanent NK cell lines. Thank you.
How do I move the slides forward?
Just tell him next.
Oh, my goodness. Okay.
That's better. He'll tell you next.
So, good morning again, ladies and gentlemen. I must say I'm delighted to be here in Bangalore, and I'm very grateful to Professor Dot for inviting me and the other members of the organizing committee to present to you. It's a wonderful honor, and I must say I agree with Dr. Agarwal that Bangalore is a delightful city. One of the things that I'm very grateful about is that I don't have to drive in your traffic. So let me begin to talk about cell therapy. If I could have the next slide, please. I also bring greetings from the University of Toronto, which is among the top 20 universities, I understand, based on the Times evaluation process. And also the Princess Margaret Cancer Centre, as it's called now, which is in downtown Toronto. Next slide. I'm not sure how that got in there. Could I have the next slide? Yeah, so I think that this is not the correct. Yes, there we are. So if we could have the third slide, please. So I just wanted to say a few words about cancer cellular immunotherapy. You know, for many years, immunotherapy was regarded as the perennially promising approach to cancer treatment. But that journey, which started many years ago, in the 1860s with Rudolf Virchow, who was the first to describe immune cells infiltrating tumors, to most recently Carl June in 2011, changed that whole landscape. And I think now it's very clear that the efficacy of cell-based immunotherapy has now been well established with CAR T cells. And I'm not going to talk about CAR T cells, but I just wanted to say, just before we go to this next slide, I just wanted to say that there are some limitations of CAR T cells that we're now discovering. Significant toxicity, cytokine release syndrome, and also limitations in the tumors that we're able to target. Now, as an alternative, NK cell therapy is now gaining momentum with clinical translation that's now increasing, and this is being helped enormously by biotech startups that have become quite interested in NK cells. So very briefly, let me tell you that there are two populations of NK cells. They represent about 10% of the circulating lymphocyte population, and the immunophenotype is as you see it there. There are two types, those with 56-dim and CD16 positive that are highly cytotoxic. They represent the majority. And then just before you, I'll tell you when to change if you don't mind. And then just the alternative then are CD56 bright and CD16 negative cells that in fact release and mediate significant cytokine release. Next slide. So NK cells are part of the innate immune system, and it's important to appreciate that they engage in non-antigen and non-MHC specific killing. There are activating receptors on NK cells and inhibitory receptors that have ligands that are class 1 mediated. Next slide, please. So what's interesting about NK cell activity and NK cell cytotoxicity is that there is this orchestrated balance between activating on the one hand and inhibiting signals on the other that are eventually going to determine whether or not a particular cell is going to be killed. Next slide. There are three mechanisms of NK cell cytotoxicity. One is granzyme dependent, so that's perforin and different kinds of granzymes. The second is killing by death receptor ligand interaction, so that's fast ligand and trail. And then the third mechanism is ADCC, which is antibody dependent cell mediated cytotoxicity, which is also related to granzyme release. Next slide. An important aspect of this is that inhibitory mechanisms play a role in when cells are encountered by NK cells that express self class 1 MHC. And if that's present, then there won't be any lysis because the inhibitory mechanisms prevent that lysis from taking place. If, on the other hand, MHC is not expressed at all, or if there is a mismatch, then that cell will be eliminated. Next slide. There's been quite a lot of activity, clinical activity. A lot of it hasn't actually been published yet, but there are a number of trials underway. By now, probably about 20 trials, and many of them are in blood cancers, but quite a large number are in solid tumors. And this may be important because it may give us a clue when we see the results as to the potential of NK cell therapy, which really isn't fully realized with CAR T therapy. The early studies appear to be safe. Could you just go back, please? They appear to be safe, and there is, even though the number of studies are limited, there is evidence of efficacy. And what is very reassuring is that there's no evidence of graft versus host disease. That is to say, the cells coming in, the NK cells coming in, recognizing the normal tissue of the patient as foreign and causing graft versus host disease, which we're very familiar with in bone marrow transplantation. Next slide. Lots of sources of NK cells, somewhat surprisingly. I'm not going to talk about any of these except to say that there's a lot of work now being done with cord blood and also placentally derived NK cells. In addition, IPS, induced pluripotent stem cell derived cells, NK cells, are also being investigated. But what I'm going to talk about are NK cell lines. Next slide. There are a number of NK cell lines, but there are only two that have any significant cytotoxic activity. And they are NK92 and a Japanese line termed KHYG1. Now, all of these lines are interleukin-2 dependent. They have all been generated from specimens of leukemia or lymphoma from patients with these disorders. And therefore, it's important to emphasize that these lines are malignant. So what we're proposing is to treat patients with malignant cells to eliminate the patient's own malignancy. NK92 is the most toxic. Next slide, please. This was, NK92 was a, we just go back. Yeah, keep going back. Yeah, so NK92 was developed by a colleague of mine, Hans Klingemann, in Vancouver in 1992. That's why it's called NK92. And not surprisingly, it has multiple chromosome abnormalities. And it's, as I'm going to show you, cytotoxic against a number of cancer cell lines and also primary tumors. Next slide, please. The characteristics I've outlined here. The doubling time is about 35 hours of this cell line. And I should indicate that the line is interleukin-2 dependent. Next slide. It possesses the following activating receptors, as you can see there, and it does, in fact, have death receptors, the FAS and TRAIL receptors. But it lacks the Fc gamma receptor. So it is CD16 negative, which means that this line cannot engage in antibody-dependent cytotoxicity. Next slide. Furthermore, and this is what makes the line very interesting and very useful, it doesn't have relevant KIRs. We haven't really been able to find any significant KIRs on this line that are relevant for inhibitory function. There is KIR 2DL4, which is expressed in, at about 40% level, but the ligand is HLA-G. So class 1 ligand, which is only, if you could go back, please. Oh, there we go. Next slide. Sorry, there's a disparity between the signal there. And so, and of course, this is found, HLA-G is found only on placental cells. What's interesting, this was done by a graduate student in my lab, is that if you block class 1 on the primary cells, there's absolutely no effect on NK92 cytotoxicity. If you could show the next slide, please. And the reason for that is that you see in the upper section the self-MHC. So what tumor cells sometimes do is upregulate class 1 to prevent to promote inhibitory action and prevent lysis of those cells. So if you block that, theoretically the inhibitory receptors then would be blocked, and so you would anticipate increased cytotoxicity. And that doesn't occur, suggesting that either the inhibitory receptors are defective or they don't exist. And it's really the latter that we've shown. Next slide. Now, many years ago, Hans Klingemann also showed that NK92 is superior to primary NK cells. Next slide. And we have demonstrated, looking at primary ovarian cancer cells, so this is a solid tumor that we obtained from the ascites of patients with ovarian cancer, metastatic ovarian cancer. And as you can see there are many of those different primary tumors that are quite susceptible to lysis by NK92. Next slide. Now, one of the things that must be going through your mind, if you're not familiar with NK92, is how would you consider giving a malignant cell population to patients with malignancies? You might, in fact, confer an NK malignancy to those individuals. Well, the answer is that one can irradiate those cells, and in fact, you can see here that you can eliminate the proliferative capacity of those NK92 cells, which means that one can then safely administer those cells without causing an NK malignancy. Next slide. There is some loss of cytotoxic ability by those irradiated cells, and at the most it's about 20%. So you still have 80% efficacy. Now, one of the observations that we have made is that after irradiation with 10 gray, many of these cells, in fact, begin to die within 48 to 72 hours. Next slide. So there have been two studies prior to ours. There have been two studies that have been conducted with NK92. One which focused on solid tumors, and basically this showed the safety of the administration of irradiated NK92 cells. The other one from Torsten Ton in Germany demonstrated that there was some evidence of stable disease, again, mostly in solid tumors. And by and large, these were, the trials demonstrated safety. Next slide. So what we decided to do was to undertake an open label dose escalation phase 1 trial. And I did this quite a few years ago, and this was an investigator-driven trial, so there was no support from industry for this, and it was extremely challenging to do. And we decided to focus on blood cancers. And these were patients whose disease relapsed after stem cell transplantation. And in the majority of those cases, what happens is that either the patient can undergo an allogeneic transplant, which is unlikely because of poor performance status, or they're given palliative chemotherapy. The objectives of the trial then were to determine the safety, the maximum tolerated dose, and preliminary evidence of efficacy. Next slide. So this was a classical 3+3 study with dose escalation. Now, I mentioned to you that these cells die off after they've been irradiated. They die off both in vitro and in vivo. And so I thought that it would be a very good idea to give doses frequently in order to have cells that were effective. And that's the administration. So it was Monday, Wednesday, Friday dosage, intravenous dosage on a monthly basis for 6 months. And of course, as I mentioned, those cells were irradiated. Next slide. There were 9 males and 3 females. The median age was 60. There were 7 patients with different types of lymphoma and 5 patients with multiple myeloma. And I don't have time to explain why we were particularly interested in multiple myeloma, but we had evidence that, in fact, NK92 has a predilection for eliminating clonogenic myeloma cells. Next slide. And you can see that the time from autotransplant to relapse was quite long, 20 months, and the time from relapse to after autotransplant to NK92 treatment was 31 months. So again, quite long. These patients were not particularly immunosuppressed, if at all. Next slide. The median number of infusions was 9, so there were 3 cycles. That's 3 months, which is a total of 9 infusions. And that's the range that you see there. Half the patients received 15 to 18 cycles, and the median dose is really quite large. It's, as you can see there, it's 27 billion. And the median follow-up is now more than 23 months. Next slide. There were no serious adverse events, and the side effects that did occur were really very mild. There were fever and chills that were brief, and they were essentially restricted to acute infusional toxicity. So while the NK92 was being infused, and we did not see any evidence of cytokine release syndrome. Next slide. 5 of the 12 patients responded, and I've listed those there. Next slide. 4 are alive at the time of this analysis, 35 months after enrollment. And I've listed 2 there. The 2 notable ones are a patient with a severe refractory Hodgkin lymphoma, who, again, all of these patients had relapsed after transplant, who is now in unmaintained complete response 12 years later, and a patient who I understand is a famous Canadian-Indian actress who remains in a remission now I think it's 4 years now after receiving the infusion. Next slide. So I just wanted to draw your attention to this remarkable case of a patient who is now disease-free beyond a decade. This was a patient who had an auto-transplant, relapsed shortly afterwards, 6 months later, progressed, was given what I would consider essentially palliative chemotherapy, and we then put him on the trial, but decided to stop because he met the criteria for failure at the 15th cycle. So instead of having a total of 18 cycles, he had 15 cycles. And the reason for that was that he developed a significant adenopathy and splenomegaly. If I could have the next slide. So what you can see here is the baseline, a normal-sized spleen, but then after 5 cycles, and it was really at the 5th cycle stage that we were able to demonstrate a significant increase in splenomegaly and, in fact, significant abdominal adenopathy. 2 years later, however, all evidence of disease had completely disappeared. Next slide. So this suggests that there may have been some kind of delay in the response that may have the megalies, the adenopathy and the splenomegaly may have been related to infiltration with cytotoxic T cells that had been activated in this process. Now, a number of patients developed anti-HLA antibodies because we had given a great deal of this foreign antigen, NK92, and it's a malignant cell line, as I had mentioned. 4 of 6 patients developed new antibodies that were specifically against HLA types, class 1, that were present on NK92 cells. Next slide. We looked at cytokine production as well, and as you can see there, there's really only transient increase in IL-6 and IL-10. Next slide. And what was interesting was that there were no detectable T cell responses against NK92. So there was some anti-HLA antibody production, but no detectable anti-T cell responses. Next slide. So the conclusion of this study is that repeated IV administration of these irradiated cells is safe and very well tolerated. And I just wanted to emphasize that there was one patient who received 150 billion cells during the course of his treatment. And there was only transient infusional fever and chills. Adverse events, as I mentioned, are uncommon, and the maximum tolerated dose was not reached. Next slide. So the conclusion here is that we did see significant responses. They were also observed at the lowest dose of NK92 that we used, and the development of anti-HLA class 1 antibodies didn't appear to confer an unfavorable outcome. Next slide, please. So, I mean, this is not bad, but it would be very nice if we could enhance the cytotoxicity of these cells. Next slide. So the 2 areas where we could do that would be somehow to confer the ability of these cells to undergo ADCC, to exhibit ADCC, and alternatively to generate NK CARs. Next slide. So the first approach that has been undertaken is to develop a CD16 positive NK92 cell line, so it would undergo ADCC. Next slide. What's interesting is that there are high affinity and low affinity variants of the Fc gamma receptor, CD16. Next slide. Next slide, please. Yes, thank you. And next slide again. Again. So it turns out, in fact, that the valine substitution in this polymorphism confers high affinity Fc gamma receptor interaction with antibodies. Next slide. So a high affinity variant was generated, and this was done through electroporation, and it also included an internal sequence of IL-2 which enabled cell proliferation to occur in the absence of IL-2 in the medium. That made it much easier to culture those cells. Next slide. And here's an example. SKOV3 is a HER2 positive ovarian cancer line, and the blue bars are the low affinity variant of CD16, and the yellow bars are the high affinity, the valine variant of the Fc gamma receptor. And as you can see there, the latter is more potent. Next slide. One of my graduate students also decided to conduct some in vivo studies in which we used an antibody directed against CD123, and CD123 is the alpha chain of the IL-3 receptor. This is said to be expressed strongly on leukemia stem cells. Unfortunately, it's also expressed on normal progenitors. Next slide. But what he was able to show was that the animals that had received the 123 antibody plus the high affinity variant of NK92 survived to a greater extent than the controls. Next slide. So what about CARs, NK CARs? Next slide. And in fact, there are a whole host of targets that one can apply, and I've listed some of those targets, but I want to draw your attention to the cancer types that are really being targeted. And what's important are the solid tumors that really haven't been successfully targeted by CAR-Ts. So when these include breast cancer, ovarian cancer, glioblastoma multiforme, it's a very bad disease, and melanoma. Next slide. So here's an example of using acute myeloid leukemia as a target, and CAR-Ts haven't been particularly successful with this approach. And the target here in these studies was HL60, which is an acute leukemia line. And you can see that the parental NK92 isn't particularly successful, whereas the NK CAR that is directed at CD33 is very potent. Next slide. So this group, this was published very recently, in fact, undertook a pilot study using a third generation CAR lentiviral construct. And in the protocol, used salvage therapy that was then followed by the infusion of irradiated CD33 CAR NK92 cells. Next slide. And the results are promising, but there are only 3 patients. And what this demonstrated, and I think this needs to be extended, what this demonstrated was that there was fever associated with this. There was cytokine release syndrome that was really quite mild, grade 1 in one patient. And a transient increase in interleukin-6 and interleukin-12, significantly higher than we observed with the parental line, and also one patient exhibited an increase in interleukin-17A. And there were transient responses in 2 patients. This is a start, and I think that one can improve on this strategy, but I think it's not an unreasonable way to go. Next slide. So the conclusions, ladies and gentlemen, and I'm sorry if I've gone over my allotted time, is that irradiated NK92 cells appear to be safe. There is preliminary evidence of clinical efficacy. Genetic modification of the parental line is not difficult and can be done with physical methods, electroporation. And they indeed show enhanced potency. There are now a whole host of new NK CARs that are undergoing early phase clinical trials. So in the next 18 months or so, you're going to see reports of these appearing. Toxicity appears to be minor and is not as significant as has been observed with CAR T-cell therapy. And treatment of solid tumors, I think, is feasible. And this is, I think, an important direction to go. There are some enormous advantages in using a cell line because of reproducibility, ease of cell manufacturing, and I think reproducible potency. That's really a very important point because you can get tremendous variation with primary NK cells. So to conclude, I think that this is a fruitful area of clinical translation. Next slide, please. Thank you. And it's these folks in the unit who really deserve the credit. Thank you very much indeed.
Thank you very much, Dr. Armand Keating, for a wonderful lecture, very comprehensive lecture on natural kill cells in Haemato Oncology. And I'm very sure that there will be a lot of questions, and we are going to take it up because you will be available throughout the day, just for the want of time, and we'll be keep discussing throughout the day. Thank you very much.